I'll be talking on the anatomy of the optic nerve head. Dr. Sachin Darwadkar sir, who is a leading practitioner specialized in glaucoma, who is working in Samartha Clinic, Mumbai. And we have Dr. Satyan Parthasarathi sir, who is my mentor, who do not need any introduction. He is an eminent teacher, an excellent surgeon and doctor. Now he'll be talking on the step-by-step approach, and Dr. Prasanna Venkatesh Ramesh, who is an exuberant and eccentric person that I have met with a lot of energy, and all of these speakers have actually is using the Spectralis OCT. Now, I'll straight away go into my topic, that is the anatomy of the optic nerve head and optic disc margin in OCT, decoding the BMO HRW and BMO MRW. I have no financial interest to disclose. Understanding the anatomy of the OCT is important because to understand the GMP program in Spectralis, we need to decode what exactly it is. Now, let's see the role of OCT in glaucoma. So once light falls on the retina, it comes to the rods and cones through the bipolar cells into the ganglion cells, and the unmyelinated axons are segregated together, and this is what forms a neuroretinal rim, which is beautifully seen in the spectral domain OCT. So here we have the neuroretinal rim, retinal nerve fiber layer, and the ganglion cell layer. We have to take all these three together to understand what is going on in glaucoma. So now I'll be dealing with the neuroretinal rim. Now, to understand that, we need to know what is a clinical disc margin. The major indicator of the optic nerve head health is a neuroretinal rim. But to quantify the neuroretinal rim, we need to see what the disc margin is and what the cup margin is. But is this a true disc margin that we see? If you take this example, if you see the green circle is a clinical disc margin. But in OCT, we have something called a Brooks membrane opening, and if you see that, it's totally different from the clinical margin in this particular example. The Brooks membrane opening is marked with the help of OCT. So what is this Brooks membrane? Brooks membrane is nothing but it is just a part of the choroid. So, and the Brooks membrane opening is a termination of the Brooks membrane. And this can be consistently detected in the ST-OCT imaging. So also we have the internal limiting membrane, which is considered as the margin of the neuroretinal rim. So internal limiting membranes, the Brooks membrane, whatever comes in between is a nerve fiber, because we know that the axons can never pass, axons and the blood vessels, it can never cross the Brooks membrane, and it must exit beyond its termination. So the true disc margin, according to this study published by Chauhan et al. And as well as the Alexander et al., says that the Brooks membrane, only after the termination of Brooks membrane, the retinal nerve fiber layers can dip into the optic nerve head. So this is a true disc margin that what we are looking at. And it is not clinically and photographically visible. And there is something, just tell something about the configuration of the border tissue. The border tissue of the L-SNC is a fibrous tissue that is connecting the scleral lip inner scleral margin to the Brooks membrane opening. So it can have different configuration. When you have the non-oblique border, it corresponds to each other. So whatever we see clinically is going to be the actual one. But in internal oblique configuration, the border tissue is internally placed than the scleral lip. And in external oblique configuration, we have the border tissue that is coming inside of the scleral lip, the Brooks membrane opening. So what we see is actually the clinical disc margin, what we see will be made of the scleral lip as well as the border tissue of L-SNC. Now the next term that we have to know is what is a minimum rim width and what is a horizontal rim width. So when we are doing clinical evaluation, what we see here is a scleral lip, and this is a cup margin. So the horizontal distance between the disc margin and the cup margin is what is a horizontal rim width. So we say that the BMO MRW is better than the BMO HRW. Let's see why it is. Because you know the geometric orientation of the axons are not same throughout the same eye. If you take one particular eye, some of the fibers can dip down perpendicular, some can go parallel. So if we take BMO HRW and fix that particular position, then you will be overestimating. So one of the example what my mentor Dr. Satyan sir says is, you just imagine the hair being tied as with a bun. So if you leave it, you think that the margin is little thicker, but when you tie it, the tie will be perpendicular to that of the axons. So that will be the exact thickness of the neuroretinal rim that we have. So for this, we have the BMO MRW, which measures the perpendicular distance from the internal limiting membrane. That will be the actual thickness of the nerve fibers there. So it takes care of the geometric orientation. So this is a BMO MRW. So this study by Chauhan et al. Has seen that BMO MRW provides a better diagnostic ability to detect early glaucoma than the retinal nerve fiber layer thickness or the BMO HRW parameter. And it yields higher diagnostic performance. In Spectralis GMPE program, there is 24 line scans which detects 48 BMO points all through, and it is given to us. So this is an animation which shows the internal limiting membrane being marked, the BMO Brooks membrane opening being marked, and it's just a 3D animation to show how exactly this works. And the shortest distance from the Brooks membrane opening to the internal limiting membrane is what we are interested in, that is BMO MRW. And the last part, the Brooks membrane in histology versus OCT. If you take the histology of the retinal layers, you can see that the thickness of the Brooks membrane is only 2 to 5 micrometer, and the RP is about 14 micrometer, which is about 3 times thicker than the Brooks membrane. But if you see the OCT picture, you can see that the RP and Brooks membrane looks equally the same thickness, or sometimes even Brooks membrane is little more brighter than the RP, thicker. So why this is because of the principle of the OCT, which actually works on the reflectance from the boundaries. In the Brooks membrane, you have 5 layers, which are all reflectile, and that's why the thickness looks more thicker. So with this, I wind up my topic. Acknowledgements to my mentor, Dr. Satyan sir and Prasanna Venkatesh Ramesh, who has been helping me throughout the journey. And next, I call upon Dr. Sachin sir to present on the pearls and pitfalls of the Brooks membrane detection.
So good morning everybody, and as we continue this same topic, which is really the heart of glaucoma imaging, we will just see how we do the clinical workflow in terms of the BMO positioning. Has it come? Yeah. Yes. So after knowing how to do it, we will see how practical it is. So this was history. So this is out and this is in. Now this is very important, that individualized marking of the scanning circle is out and automated marking is in, and that this itself is the holy grail of imaging. So BMO is the holy grail of advanced glaucoma imaging, is something that everybody should know. And BMO is the Brooks membrane opening, as we have seen. So it's not clinically visible, it's BVR, like the BVR missiles. You don't see it at all, and the machine fires it for you. What it gives you is the repeatability and reproducibility, because of which it has made progression assessment a real possibility. It is user independent and it is automated. So all these make it a reliable tool for minimizing the test-retest variability, and this really differentiates the men from the boys in glaucoma imaging. So deviation in clinical disc margin and the BMO is very well known. Why manual is out and automated is in is this, because in the manual you cannot see the Brooks membrane opening, because of which you cannot mark the clinical disc margin. So this BMO is way out of the clinical margin. This is nearly similar and this is superimposed. This is impossible to detect by the human eye, because of which it will also affect the scanning circle in the RNFL analysis. So posterior segment imaging in glaucoma consists of the ONH, the RNFL and the macula, as rightly pointed out by Swati. The correlation of these three and the one neuron concept is very important, and we have to never report each and every structure in isolation, which was the mistake committed in the last few decades. Masterly workflow makes the difference between use and abuse is something that we should know. So the study of OCT for glaucoma begins here with this image, which is not available with most of the machines and which is not seen by most of the ophthalmology consultants. So when we see the BMO overview, we get the segment-wise view of the Brooks membrane opening, which we can verify. We verify the segmentation, verify the positioning, and see that everything is in order before we go to the next step. So go to this. Because it is not available in many devices, this image is not seen in any of the printouts which are described in common lectures. Now, why precision and checklists matter is very important, because there are certain things which cannot be missed. One is the rim analysis. Once you've done the checking with the BMO points, you go to the rim. Then see for the profile. If you see the profile and if you see local dips, you can go again to the same sector and recheck the placement of the Brooks membrane opening. And then second thing is you go to the deviation of the Brooks membrane opening. Now if that is more than 100 microns, you know it is not comparable to the normative database, because of which the color coding will go for a toss. So these are very, very fine things, and precision matters when you use this for glaucoma serious glaucoma imaging. Now you can see the effect of the BMO on NFL scan circle placement. Because you cannot see the center of the BMO, here you may be sometimes right in placing the scanning circle, but here there is no way you can place the scanning circle in the position which is required, because you just can't identify the BMO. So this is very, very important clinical correlate why BMO centration and automation is very, very important. Now BMO overview, the examination in all centers, all sectors, and localizing it and classifying it is due diligence, without which you should not be proceeding with the analysis of a particular image. So due diligence is mandatory, otherwise there is no difference between use and abuse. If you can see here in this image also, you have BMO localization that is precise. In every sector of the 12, you can see the BMO and the ending precisely, very, very clearly, even clear to the normal human eye. And all the sectors are classified depending upon the normality in terms of red, green and yellow color coding. Very, very simple, very easy, but mandatory. Knowing that, you have to know that imaging has its own limitations and identification of which is important. Now if you see this image again, the due diligence that you are doing, you will see the image below here which has gone for a toss. So irrespective of how good your device is, optical devices have their own limitations, and you should be absolutely sure of what you are looking at. So in such cases, try to reacquire, alter the image contrast, look for the choroidal wedge and redo the BMO at suspect locations. Now this all is not possible with most of the machines except the Spectralis, and that is what impressed me the most about this machine. I have no financial interest though. But this gives you the cutting edge in ophthalmic diagnostics as far as glaucoma imaging is concerned. Look at this, you have to beware of disc tilts and torsions. It is an immediate red flag. The moment you see a disc like this, you have to go to the 12 images to sort out whether the BMO has been identified correctly. And as you would realize here are the few places where the BMO location visible to your eye and what is marked by the machine is different. So the moment you see this, you have to be sure that, or you have to be reasonably sure that there may be some variation as compared to what you should be anticipating clinically. So it's very, very important to see these sectors and put them in proper perspective before you go to the normative database and compare. Having said that, comparing such discs to normative database is fraught with danger. You can do it with the RNFL or the macula rather than doing it at the disc margin in such kind of cases. Again, in this case, you see the Brooks membrane opening is lying somewhere else, the clinical disc margin is lying somewhere else, and rightly here you can find out that there is no data that is being acquired, no marking that has taken place. So why this is important is in some kind of optic nerve heads, irrespective of the number of times you do the examination, it is impossible to get the Brooks membrane opening, and which is a limitation that you should absolutely understand. Clinical correlation is very important, and this is another example of of such a case. Now here you can see all the sectors are green. So even though all the sectors are green, doesn't mean that everything is normal, because this is just an image. This is not going to give you an answer. This is going to help you answer. So just remember that clinical correlation is the most important thing, which we shall see in continuation in the next episode. That is my next talk of the next 6 minutes. Thank you for your patient hearing. No, we can continue later, because I have kept that case as the last movie.
Thank you, Dr. SWETHA, and good morning to everyone here. I'm going to discuss something about the Brooks membrane opening, mainly the minimum rim width, step-by-step approach. Of course, we have this, the Garvey-Heath grid analysis, how we can do that, and also the Hood report. I am Dr. Satyan Parthasarathi from Coimbatore. So when you take the OCT, we have two areas of interest. One is the optic disc, and we have the ganglion cell layer. These are the two areas of our interest. I'm going to talk only about this, the neuroretinal rim, the minimum rim width. Of course, we all need to have a very systematic approach when we are looking at the OCT. That is the rim, then you have to look at the RNFL, and then we have to look at the GCL map. So I'm just going to discuss only about this minimum rim width here. So one, of course, there are about 24 radial scans, and there are about 48 Brooks membrane opening points, which Dr. Sachin was describing. So let's look at this minimum rim width and what is all this, the Garvey-Heath grid analysis is all about. So this is basically a 6-sector Garvey-Heath grid is aligned with the anatomic positioning system, which will be described by Prasanna a little later. So the grid is basically optimized for the GCL arrangement. So we'll probably the subsequent speakers can show you that the GCL mapping. So how we really look at that in a clinical way is the printout comes like this. Most of us are used to the printouts, but what we do in our OPD is mostly looking at the screen directly from the machine. That is the best way that you can really see. But this is another way that how you can really see the printouts, but we'll just go step by step. When you see in the machine, this is how you see that. There are 4 zones will be seen. We'll just take you through that. So this is the first area, what Sachin was describing earlier. You have to look at the Brooks membrane opening point, and also whether the minimum rim width area is marked properly. That is the yellow marking. If it is not correct, then whatever the scan you have done is not going to be useful, and readings are going to be completely a waste. So make sure that all the 9 quadrants have been taken care first. Then the second area is the B-scan picture to show that how regular the line is. You can see a green line, then you can see the black line. The black line is the actual thickness of the Brooks membrane, not the Brooks membrane, the minimum rim width. So that is the second area. But if you have any problems, of course you have to see the ILM marking. If the ILM marking is wrong, the red line over the picture 3, if the ILM marking is not correct, then I'll just show you a video also. Then you have the zone 4, how the BMO is being marked. You can see those red dots, that is the Brooks membrane opening dots. And then you have the Garvey-Heath grid. So just look, So the minimum rim width is basically compared for the ages between 20 to 87 years. If somebody is below this or above this, this is not going to be useful for you when you do the scanning. So the Brooks membrane opening MRW analysis chart, what does that 3 lines show in that? One is the green line. The green line is basically meant for, that is the baseline. And if the line comes, there is a black line. That is the line, the actual scanning line. Shows if the thickness of the optic disc is, the diameter of the optic disc is smaller, how it will show. I'll just show that. And you can see there is another small gray line, that is the follow-up line. So there are 1 or 3 lines. Totally will be 3 lines if it is follow-up is being done. So we'll just describe that one by one later. This is a small video clip about the Brooks membrane opening minimum rim width. You can see that there is a small area in the red marking I've done here. This is abnormal. So once you see something like this, then you have to just go back and see whether the ILM is being marked properly or not. Here you can see that ILM is not been marked properly. So you just have to go to this area, click this button, and then you can see that it goes to the ILM, proper ILM marking. So click the ILM, and then you can see that there's a round is there. This is the only instrument where you can really adjust your proper ILM marking and also the Brooks membrane opening. All the equipments of the OCT works on the AI principles, but unfortunately in other machines we cannot change anything. This is the only machine where you can do all the changes. So your measurements are very, very accurate. So once you have done the ILM proper marking and you can save and close, immediately what happens is then it will get changed. So you see here, now this arrow mark that the dip has gone off. So this is how you change the ILM and then get a proper BMO MRW markings. So if you have the defects, you can see the black line here. The black line goes up and down, and you can see this is the moderate defect here, and then you can see that the defect of this black line is touching the red zone in almost all the quadrants. So that is a severe defect. And you see here that is a localized defect where only one area, that is inferior nasal and inferior temporal area, has gone down. So with looking at this B-scan map is essential, and you can really look at where exactly is the damage happening. So what is all this, the macropapillae and micropapillae? We are all used to see the big disc and the small discs. So what is the importance? When you see the macropapillae, the whole diameter is so big, and if you see the micropapillae, the diameter is smaller, but if you have the same amount of nerve fiber layer arranged, then imagine with the circle is bigger, it is sparsely there. But if it is smaller circle, then you can see the density of the fiber arrangements. That's why you see here in this B-scan map, the micropapillae, the thickness is going to be much higher. And you see the macropapillae, that the thickness is lower, so it is just lying below the green line of the baseline, but it is within the green line itself. It is not touching the yellow or the red. So this is one thing which you will have to understand. Sometimes when you see this is down, you should not think the patient is having a damage. At the same time, when the micropapilla is arranged here, then you should understand that there is something is going on also. So this is the same thing which I was just trying to discuss, how you can really look at the localized area of damage. And this is the same line which I was just describing. So coming to the Garvey-Heath grid, so what is this? You can see the red. So that means the damage is less than 1% in red, 1 to 5% in yellow, and if it is normal, that is more than 5%, that is in green. So that is easy for us to understand. So just understand this grid. You can see that I just put one sector separately. Shows that minimum rim width is about 298 microns. That means it is, you can see that there is 40%. It is not 40%, it is 40 percentile. So that is important for us to understand. A value of 40 percentile of the normal means it is the 60% of the patients in the age-corrected reference database have thicker MRW values, while 40% have MRW values of this size or thinner. So this is critical for us to understand. When we have the discussion, we can go through that. So just to go back again, this is how you see the printout. This is a normal. You can see the Garvey-Heath, everything is showing green. But all of us have the habit of something seeing in the visual fields the gray scale. But never do that. Always see the B-scan. First you see this map, see the B-scan map, and then only you have to come to the Garvey-Heath grid. Don't jump into the, you can see in this, all these have been marked properly. Then you see the Garvey-Heath, where exactly is the damage happening. So understanding the Hood report, what is this Hood report is all about, is basically looking at the visual fields, correlation of the visual fields. So you have RNFL damage over there, which is been shown in the B-scan map, and of course in the RNFL, and as well as in the Garvey Heath, that is MRW. It has to correlate, otherwise it is not going to be proper. If everything is correlating, then you look at these deviation maps, you can see that RNFL change, there is no RNFL there, so the blue is the defective area. And then similarly, when you see the GCL map, again you have an area where there is a defective GCL. So just, we all understand the fields is always the flip. So if you look at this area, you can see that the change is happening over there. That is the 24-2 visual fields. It is compared to the Humphreys. And you see here, this is the GCL map, which is the central zone, central 10 degrees. So it is 10-2. So we can easily correlate in the visual fields here. This is 24-2, you can see the NFL change. And you see the 10-2 here. You can easily understand the GCL, it is much more in the central 10 degrees. So we can easily correlate these defects. So coming to the MRW Garvey Heath progression analysis, if you just click here, there is a button over here, you just click the progression button and then you can get this chart, and then this chart will show, there's one area here to show all the sectors to superior temporal, inferior temporal, nasal, all that. You just have to go click that and then it will show each follow-up, how much is the thickness in these patients. So by this, you can understand what is going on for these patients. The thickness, is it the same? Sorry. Is it the same that is happening, or is there a change over a period of time? You can have multiple follow-ups, and then you can see what the average thickness it is maintaining. That is a normal thickness. If it is something below, then you can understand, okay, there is a real defect which is happening. So it is easy for us to understand, but the reason why I am emphasizing is that you see in your system is when you have the printout, you cannot have so many printouts to understand how the progression is happening. Because each area you can go click and then see what is happening in each zone. Yeah.
See, if it is visual fields, I know it can go up and down.
Yeah.
That means if you're having spots coming up and down the regression line,
Yeah.
then it indicates that there are outliers. How do you get an outlier?
If you have not marked properly, then you will have the outliers.
As you rightly pointed out, you see an outlier in imaging.
Yes.
You have to revisit your image.
Absolutely. Yes. So we'll have the discussion time, then that time we'll see that. That is an important point that which you have raised, though these are all automated things, but each visit we have to do the proper BMO marking and the ILM marking, otherwise you are going to have a problems. So what we were discussing about all this time is looking at the optic nerve head, radial and the circular scan. That is what we were discussing about. So thank you so much for your patient listening, and thank you, SWETHA, for the opportunity. Yeah.
Thank you, sir. That was an excellent presentation, and it's really important to see the stepwise approach, and as sir rightly pointed out, we have to see everything in our system. Only then we will miss the segmentation errors. We have been doing this in our clinic. Each patient, we are reviewing it, and we have to see the BMO points, the ILM points. Even if you take a little time, it is okay, because we need a baseline, proper baseline. Only then we can go for the progression analysis also. Next, I call upon Dr. Sachin sir to discuss on the posterior pole asymmetric analysis.
Actually, the topic is 3 in 1, no? RNFL, asymmetry, and this thing. Just let me see. So, in short, it is basically everything in a nutshell. We will be going only to the practical points strictly, no theory slides. So, you always remember pattern of ganglion cell death is different for different types of glaucoma, different for open angle, different for acute angle closure. The neuron is the entire thing that you should be seeing, not the head or the tail. So, don't see an elephant, you see an elephant like this, not like this. So, see from the optic nerve head to the retinal nerve fiber layer to the ganglion cell all at one time. That is very important. So any number of maps presentations that are available, make sure all the 3 are in one map if you have to be reasonably sure. So once you do the BMO analysis, the next thing you do is see the entire ganglion in one picture. So here we have the overview printout in the spectralis, which I'm addicted to once I'm sure with the BMO MRW printout. So structure correlation it is, and that will get all the 3 structures in one. Now let's see how it applies clinically. See, this is what about Dr. Satyan was telling about the statistical parameters. See, you did the OCT because you suspected something, not because you have a machine. That's what I presume. So when you suspected something, look at the area which you suspected rather than looking at the values the machine is giving you. So here I suspected inferotemporal thinning of the nerve fiber layer. I did the test. Here everything appears green. I should be happy. But the moment I see the green color, I will forget that there is a notching here. If you can see, the ganglion cell pi is eaten already. And that's where I was actually supposed to look when I looked at the map and not at the interpretation. So always look at the areas of suspicion and not the interpretation. That is what you bought the machine for, because interpretation is your baby. So simple things. And now when you go here, even if you see statistically, it's just almost on the verge of tilting into abnormalcy. So look at those percentile values very, very carefully. They will be almost tending to abnormal in such cases. So be very careful and look at this curve rather than the numbers. So inter-eye asymmetry is another thing, 3-in-1 map, that is the glaucoma overview and clinical correlation. Now see, this is a very prototype case. Okay, so you have this right eye of the patient, you have an inferior notch, very, very clear. You see the rim thin inferotemporally, you see the RNFL thin inferotemporally, and you see the ganglion cell knocked off below. The hemispheric asymmetric map is obvious. This map here is the entire NF, the thickness is lost, and this is a pretty open and shut case of glaucoma. So don't fall into the color identification or pattern identification trap. Now you see this here. Here you are suspecting, this is a doctor who came to me, left eye clinical suspicion was there, we did the test. Now always keep 2 maps side by side. Sometimes the value may deceive you. Here we have, again if you see this hemispheric asymmetry, I am not at all impressed by this. You know, most of the time it will be ambivalent. In my 12 years of experience with Heidelberg, this is the most useless map, if I may say so. So see at the other maps, they will give you a lot of information. Here you can have, here you have again inferotemporal thinning, but here again you have a green color. So is it normal? No. Look at the value, 5 percentile. And it is not that it should be exactly here, it can be slightly here also. Okay, so look at this part, in general it is thin. You have an inferotemporal thinning here, and obviously the pi again is eaten here with a hemispheric asymmetry. So very, very obvious. This I call as the 1, 2, 3 pattern. Very, very diagnostic of glaucoma and nothing else. 1, 2, and 3. So on my OPD paper, if you see some patient comes to you, you will see 1, 2, 3 plus. That is this. Very, very simple thing. That means you have done the due diligence of looking at all the 3 structures at one time, and you have done the structure-structure correlation. Now, how inter-eye asymmetry is important? Here you can see both eyes are inter-hemisphere asymmetry. So here you can see both eyes are abnormal. One eye is slightly better than the other, but this is an obvious defect. Okay, so you have a notching here. Clinically, you have a notching here. Here you have an inferotemporal thinning. The isn't rule is broken, but obviously there is a gross difference between 2 eyes. Even if you see the average thickness 224, 187, 103, and 82, and obviously a sectoral thinning with a notch. Now, if you see here, relatively everything is okay, but this map is giving some non-specific information, pixelations, which is not going to really help you in decision making at all. That's why I said that is pretty non-specific for me. I don't see hemispheric asymmetry, but rather I would see the inter-eye asymmetry even in these hemispheric asymmetry maps. So here if you see in the 2 eyes and as well as in the 2 sectors, you have a gross difference, and that's the only help of the hemispheric asymmetry map. More than that, I wouldn't give too much of importance. But inter-eye asymmetry, yes. the values will be different in the two eyes, and that will tell me that there is something going wrong. And here again, as I told you, the 1, 2, 3 rule is followed, and this is a classical case of glaucoma. Now, this is the last example, the great Shane Warne, the bowler of the googly. So I just continued with the last MRW example. You want me to show you again the MRW? In this case, I'll just go back to the last PPT, and then you can put this in perspective. So this was the MRW of the last case. Yeah, so all in the green, all statistically normal, all sectors agree, Brooks membrane opening identified properly, termination, vertical, perpendicular, everything fine, everything normal. Okay, so now I go back to the PPT that I am doing right now, and let's see why Shane Warne will be happy. Yep. So now you see this. Upper one green, lower one completely red, ganglion cells gone. Yeah. So what is this? Is this glaucoma? Sorry? Okay. I am very loud. Yeah? Oh, okay. In the recording. Okay, fine. So, is this glaucoma? Is the question. Now, here is where we look at the case in toto. This case was referred to me by somebody. Now, what I didn't tell you is, this patient had pressures of around 30 for the last 6 months, and the patient was not being treated because the cup disc ratio was 0.3. Because the person was treating was not a glaucoma specialist. Now, because it was 30, he said, no, but he had classical biaccurate scotoma. But no, disc is normal. So it may be ocular hypertension. What he did not realize that this is full of disc drusense. Now, what is remaining is the drusense. The nerve fibers have gone. So the machine is measuring the drusense. Yeah. BMO. Yeah, you can. So, but for the person who cannot see the BMO MRW, that's the whole point, right? You don't have the image of the BMO MRW. If you don't have this OCT and you don't have those 12 scans, then you are straight away bamboozled here, like Warne used to do. So here basically the nerve has completely atrophied. What you are measuring here actually is the drusense. The nerve fiber layer is gone and the ganglion cell is gone. So this is actually an open and shut case of glaucoma, and this is basically seen by you because you are actually measuring the drusense, and this is never going to reduce. This will be the same throughout his life. So this is very, very important. Why clinical correlation is important. Irrespective of the device, it is your brain that is going to take the final decision. Thank you for your patient hearing. Yeah. Correct. You want me to show it again, or in the discussion we'll take it? Yeah. Prasanna is here, I don't think. Is he here? Yeah.
Actually, going back to the basics. If you do a good slit lamp examination and binocular view, you can pick up the drusense.
You can easily pick up, sir. The problem is,
if you go according to the machine, that's what it is.
no, but the consultant went by CT ratio. You can pick up the drusense is okay, but this was a mistake that was committed. So the essence is that if you see the imaging
Totality, that's what it is.
totality, yes. And if you see the imaging is giving you error here.
Yeah.
Again, if you don't have the BMO MRW images, the 12 images of the spectralis, there is no way you can identify the drusen on imaging. I am saying not on the clinical is obvious. So the moment I saw the consultant who referred it to me, I told this is optic atrophy. This is only the drusen that you are seeing, there is no nerve.
And you can see the activity.
And because of the OCT, the open and shut case was The moment you have a total ganglion cell body atrophy, no RNFL, you know that it is obvious. See, madam, what?
So I'm actually coming back to that. So if we do a good clinical examination, go by the IOP, go by the actual this papillary atrophy and the drusen, then you still come back. So what I'm trying to say is, yeah, if you have the machine, it's good, but you can also do it without the machine.
That's what the point was.
Here.
Do a clinical correlation.
HDMI.
I give you the history later.
You have to have a machine and you have to have something clear.
The point is don't depend on the machine.
Yeah.
So machine can fool you, so use your.
Yeah, the systematic approach, don't jump into
Yeah.
like what is
Prasanna Venkatesh.
jumping into a grayscale is the last thing which you do. Similarly, that's what you have to see. You have to go through systematic approach.
And even the disc vessels also take some time to get laterally shifted. In chronic glaucoma, there is more of vessel
Connector
shifting.
is there?
If you have 30
Connector
pressure of
is
only
there.
6 month duration, vessels are not shifted that much, so it happens.
coming.
And
Give me your connector.
yes, yes, shifted. So cupping is the response to chronic elevation of IOP, and pallor
Wait,
is
it's
a
coming,
response
it's
to acute IOP of short duration. Yeah, and multiple pathologies can coexist. Even the coloboma disc can develop glaucoma.
Better than I got this case 3 days ago. So it was good for us.
Opportunity, Shweta. I think we had a discussion about the machine and maybe if I'm not wrong, how the machine makes a slight difference. So no financial disclosure, but I'll just take you through the impact of fovea BMO center and the anatomical positioning system, which is more like a GPS for this particular technology. So to start off, I think you would have all seen the animations of ILM getting mapped, the Brooks membrane opening getting mapped, and what is the BMO MRW. I think we have all covered about the Brooks membrane opening minimum rim width. So let us see something more as to why this is more important. So this is a glaucoma module premium edition, as the spectralist would like to label it. And I'm going to take you through this particular boxes here where it's more of an anatomical orientation as to how RP is over BM and the BM is over choroid and the choroid is over sclera. So this GMP actually has an anatomical positioning system, because today we are more dependent on GPS. It's still debatable, as we had quite a good debate now. But this GPS, what it gives you an extra edge is, if there is an eye movement with a single beam, we are not able to track the eye movement. But with a dual beam, you can see that even if there is an eye movement, the tracking is actually very meticulously done. So that is one advantage with this, because same piece of tissue is examined today, 1 year later, and even 2 years later, or whenever we have the follow-up, because of the dual beam live tracking. So again, you can see this is how the animation is done, and in reality you can see, however the eye has a micro movement, the same piece of tissue examines, and papers have shown less than 1 micrometer difference between two readings taken maybe on the same day, slightly apart. So the variability is quite minimal, and 16 scans per second is what the machine has to offer. So technology wise, still no financial disclosure, but this is what it really gives. So first it plots the center of the fovea, and then it plots the center of the Brooks membrane opening, and then this center and this center is matched with the fovea BMO axis, called the FO-BMO axis. So once that is plotted only, now the next curves are centered on this. The Brooks membrane opening minimum rim width is now centered on this, and then you can see the RNFL and the ganglion cell inner plexiform layer orienting itself after the fovea BMO axis is plotted. So that is a unique feature of this particular APS. So this is a patient whose head position is normal. The same patient, when the head is slightly tilted, you can see the superior temporal area goes in for a slight thinning. It actually confuses us. Where you can see the fovea, which is actually down, is now seen as if the fovea is on top. But that's not the reality. So this is what happens when the patient has a tilt or a cyclotorsion. But the same patient, head is in normal position. With this technology, even when it is tilted, you can see that 140, 142. So that is the particular fovea BMO axis, or the APS plotting this particular thing does, which is quite actually very useful. So the impact of fovea BMO axis is, you can see, this is a +6 and this is a -7. What does it mean is, if this patient is just plotted without the rotation, it is actually wrong, because the fovea is actually slightly situated up, and here it is down in -17. So this is wrong if you don't rotate it. Only if you rotate a clockwise rotation for a fovea which is situated on top, and for a fovea which is situated on bottom, the machine slightly rotates it anti-clockwise. So thereby slicing it from the center of the fovea to the center of the optic nerve head. So that is very important, and that's where this kind of reporting, and it also generates a Hood report. So we also have a visual fields in the next session where you can also join with us, where we'll be talking about the correlation of this. You can see, since the same piece of tissue is examined, I think from 2019 to 2020, this patient is having a control of IOP, and I'm thinking he's actually improving in his target IOP, but in reality, I'm just able to sense there is a mild progression of his glaucomatous defects. So these things are only possible if we examine the same piece of tissue. Just by getting the IOP under control doesn't mean the patient is not progressing. So these kind of reports in this OCT gives me an eye-opener that I'm still not on the right plane, I have to do something more. And this is one of our papers which we have published in the Indian Journal of Ophthalmology, me along with my mentor, Dr. Satyan sir. I would like to thank him at this moment because he's been the one who has taught me A to Z in glaucoma, and he's being here with me. Thank you once again, sir. And without much time, I'll move to the next part of the talk, which is just a 2 minutes one. Confounding factors. So we saw about the fovea BMO axis. So what it is actually capable of. So in fovea BMO axis, now we'll move to talking confounding factors, red disease. What happens when we have a myopia? What happens when we have another disc which is quite tilted? So God has given us this kind of a thing that we don't have the same optic disc. There is a huge variable of optic disc that is available. Again, I'm reorienting you to this basics where RP is blue, Brooks membrane is red, choroid is yellow, and sclera is green. So what are the alpha, beta, and gamma zones? This is a very, very important point that we need to know. In our post-graduation fellowship, this keeps coming back and back. So what we think in reality is we see the optic disc margin as the end of the sclera, Elsning ring, but in reality it is not that. There is a slight difference, the red line. The red line is what is the ending of the Brooks membrane. That is the real definition of where the OCT is getting terminated, the termination of Brooks membrane. So there is a slight change in concept that what we see in our fundus is not what it actually is. The true margin is actually the Brooks membrane, and Chavan et al. Has proved it in his paper. So now, categorizing the ideal situation. In an ideal patient, when the BMO margin that we saw matches the clinical disc margin. So usually we would want the BMO margin to match the clinical disc margin, and there will be no hyperreflectance surrounding the optic nerve head. So this is how it will look. But what happens when the BMO margin that we see in the OCT that doesn't match with the clinical margin that we see in the fundus? That time what happens is we get an hyperreflective surrounding the optic nerve. So this is where the tricky part sets in. So when this comes in, we have peripapillary atrophy, we have conus temporalis, and PPA and conus temporalis. So I'll just give you 3 slides on what these 3 are, and we'll end the discussion. So how to categorize this hyperreflectance? So we have alpha zone, beta zone, and gamma zone. Alpha zone, BM is present, and irregular RPE is present. In beta zone, only the Brooks membrane is present. So that means in alpha zone, we have this RPE and the Brooks membrane. And in beta zone, we only have the Brooks membrane. In gamma zone, no Brooks membrane and no RPE. We'll have only the choroid and sclera. Now peripapillary atrophy, you can see the RPE ends here, but the BMO comes up to here. So I have made this slide here on top. RPE ends, but then the BM, choroid and sclera continues up till here. So now what happens is this area is the hyperreflectance area in peripapillary atrophy, this particular area here. So again you can see. So due to the temporal RPE absence, in this area the RPE is absent, so more light reaches the underlying structures, so they appear hyperreflective. So this is that area, and this is the alpha and this is the beta. So now we can see, again I'll just show you this. So the hyperreflectance area is this area because the RPE ends, here itself the RPE ends, and this area is the hyperreflectance area. Moving to conus temporalis. In conus temporalis, RPE, Brooks membrane, and choroid end at here, and the sclera continues. So in conus temporalis, you can see the sclera alone continuing. So this is what we see like a temporal myopic crescent here, and that is the RPE and Brooks membrane end together at this point, and then the hyperreflectance is seen here. So that is where the absence of RPE and choroid at this area enables a direct view on the sclera, and therefore a white sharp demarcated hyperreflective zone gamma. So this is the zone gamma where there is no RPE, no Brooks membrane and no choroid. This is the gamma zone. So this is conus temporalis. What happens when conus temporalis and peripapillary atrophy are present together? So see on top, first the RPE ends abruptly, then the Brooks membrane and choroid end together, and then the sclera comes out. So this is quite a complex phenomenon which gives us a lot of nightmares, because you see the real margin is in between the hyperreflectance zone. So you can see this is where the real margin is present. In the previous cases, we don't have that confusion, but here, where the Brooks membrane ends, that is where the hyperreflectance zones are present. So the RP ends here, the sclera ends here, but the Brooks membrane is in between them both. So there, the hyperreflectance region, in the center of the hyperreflectance region, we'll have the Brooks membrane. So this is alpha, this is beta, and then this is the gamma zone. So when our conus temporalis and a PPA are together, we have the alpha zone, the beta zone, and the gamma zone. So with that, I'm ending the two talks, and I thank SWETHA for the opportunity. And once again, I thank my mentor for giving me the knowledge and wisdom on glaucoma toolkit. Thank you for all the attendees. Thank you.
Thank you, Dr. Prasanna. That was an excellent talk. Now, we'll go for some question and answer sessions. Do you have any doubts?
We have Dr. Rangaraj also is here. Though he is using a different machine, I think. Yeah. So Spectralis is one of the very advanced technologies, but what we are trying to say is just having the machine is not enough. Understanding each zone is going to be the critical way that you look at the maps. So to re-emphasize, just looking at the printouts and coming to some conclusion is not the way that you do, whether it is for the visual fields or OCT or fundus or whatever it is. So just try to connect your systems through your LAN ports. You can just request the companies to do the connectivity for all your systems. It is not that difficult. It is just the attitude that we have. Just connecting to the LAN port in your hospitals is going to be very easy. So you go to the, the stalls here, whether you have a Heidelberg machine or any other equipment that you have, then just request them to connect it through your LAN ports, and then see in your laptop or desktop in your workroom. So with that, I think, yeah, please, sir. NIDAC, every machine has, sir.
I have that.
Yeah.
So basically what you look for is the thinnest margin. Just follow the thinnest margin. It gives you only one report on that, the BMO versus that. So you just look for the thin margin. And that's supposed to be very diagnostic. So just look for
We'll
that.
just remove this.
Again, like he said, it's the overall thing which we look at. Not so much just only that a machine is making it. It gives the probability that there is a problem, and it's for us to benefit.
See, but whenever you purchase any machine, always remember the reason for which you've done it. You may not be doing exclusive glaucoma practice like all of us. So the moment you want to do exclusive glaucoma practice, then the demands become sky high, because you are going to look at progression on an OCT. Why people are blaming OCT all the time is because they don't realize that OCT has limitations, and the limitations are imposed by your pocket, not the machine. So NIDAC as well has a higher end machine. It's not as popular as the others. Spectralis has the longest history, maybe a couple of years ahead of its peers. I have no financial interest again. We can show you the reasons why methodically. But the point is, a machine that is costing you 25 lakhs and a machine that is costing you 80 lakhs is a reason in between. And it's not just the 50 lakhs for nothing. The tracking hardware is everything that matters in a machine which can go, stretch the limits of imagination. The tracking and the speed are the two things which make a difference between using OCT for progression in glaucoma and just OCT for the first time diagnosis. Because when you are doing a manual scanning circle placement, many things can go wrong. If you were there for my first talk, you would have realized manual scanning circle placement is out, it is history, it is dated. So if you want to place the scanning circle with your own hands, it is fraught with errors, it will just give you a one-time diagnosis. If you want repeatability and if you want the correct answer, it has to be automated BMO centered scan. That's it. And that will not be possible unless you have a high-end machine. Okay, thank you. Yeah, sure, please. That is the reason why the IC
Yes, yes. So, so that is the reason for us to show you the micropapillae and the macropapillae. Macropapillae, the MRW is going to be much more thicker. In the macropapillae, the MRW is going to be thinner. And also the reason for giving these percentiles. So that gives you a better idea to understand what is actually going on. So I won't say that is exactly this is going to be the thickness. This is all been age matched also. So age matched, and also depending upon the MRW values and the macropapillae and the micropapillae. There are too many variables that you will have to look at it before we come to an understanding. And also, if you look at the sector wise, the Garvey Heath, the problem is you are not looking at one particular area. You are looking at a average. So that's why I said you look at the B scan of where it is really dipping. So you pick up that area, and like what Sachin was showing, you see the dip and correlate it with the GCL map. If you are not correlating that, you have to have a problem with your MRW. Similar area you have to have it in your RNFL, and similar area in your GCL map. If that is not correlating, then you have to go back and see why it is not correlating. Like what he has shown is very interesting case of optic disc drusen. Patient has already finished colors. Now we are just looking at the green zones. So we have to understand every sector properly, and then you understand that. Okay.
Just one more point. Always remember that the database is finite. Database is finite. 500 Europeans, 200 Caucasians, 250 somebody else. It cannot be representative of the entire population. So always, if you see the apex of what we call the evidence-based medicine, would be comparing the patient's own scan over time. So if you have two good baseline scans, in fact for spectralists you don't need two scans, only one scan is sufficient. So one good baseline scan, and you compare it over time, that itself is the holy grail of treatment in glaucoma. Because once 250 people cannot cover all the permutations of disc size in the world. They cannot cover all the permutations of peripapillary atrophy, the alpha, beta, gamma zone. So all these things have their own limitations. An excellent feature which is again not there in most of the machines is the delta BMOC, which will tell you whether what you are comparing is the normative database of the machine worth comparing to your scan. If it is not, it will tell you straight away, don't even look at the normative database, just go by the progression data. And that's a very, very important piece of information. I mean, it has to be discussed in a much bigger talk, but just remember this, it is machine specific, and the best thing is if you have a progression software, if your machine is capable of progression, that is the thing you look rather than the normative database.
Yeah, that's wonderful, Sachin. That's why we say that systematically go and then see every zone. BMOC, again, if it is less than 100, it is okay, but we don't go up to 100. Somewhere around 20 to 50 average is fine, but beyond that is not very good scans. So look at the B scans, look at the BMO points, whether it has been arranged properly or not. Look at the MRW, look at the ILM. Every zone you look at it before you see the Garvey Heath or the hood maps. Yeah. I showed that, yeah.
So, supposing you have not done it in the initial one and you already had a focal defect, you treated the patient. So, while you are doing the progression, can you go back in the
No.
machine and do it?
No. You have to take that, whatever you are taking now, that as a baseline, and then start doing it. You cannot go back.
You cannot do it after some time, you cannot
You can. Still, you can go back to your old one, and then you can change that. This is the only advantage which you have in your spectralis. Profiles you can always change.
One last question.
Yeah, please.
Before you go. What about in myopic discs? You get all these weird discs which was addressed in the last talk.
Yeah.
So progression in myopic discs is very hard.
Same way you can do that, because we are looking at the BMO points in this rather than the clinical disc margin. So that is the biggest advantage of looking at the BMO points.
Okay.
And also when you have in doubt, you can always look at the GCL maps also. Of course, GCL map in myopia also will be a little changed because of the thinning of the retina happens. but you have to see in isolation about the GCL map. When you look at the retinal thickness map, it will show very thinned out. But you see the GCL map, it may show definitely a little bit of thinning than your regular patients, but you can still correlate and pick up the defects.
Arneffel map is very safe in most of the myopes.
Yeah, because
Papillary atrophy may not extend to the 3.4 millimeter scanning circle.
yeah. That is one advantage again in the spectralis, that you have a 3.5, 4.1 and 4.5 circles. So even if the disc is bigger, you delete your 3.5 look at the 4.1 and 4.5 circles. So no, because the disc is so big, the RNFL is not going to be in that over that area. It may be just masked. So you can look at 4.9 and 4.5, which will give you a better idea of how the RNFL is.
We are not deleting it. We are just seeing the circles.
Yeah, we are not deleting any data. Anyway, I think we can definitely discuss that because we have to move on to the next topic.